Bismillahirrahmanirrahim. Assalamu alaikum, all participants, our panel of experts and our speakers. Can you all hear me? Can you just write on the chat box if the voice is clear?
Yes, I can hear quite well.
Okay, great. Thank you, Dr. Yusuf. Well, on behalf of Farmevo, we welcome you all on the 4th International Hyperuricemia Summit, which is virtual on this year. Before it starts our proceeding formally, we like to start by the name of Allah Almighty. For the recitation of Holy Quran, I like to request Mr. Khalid Arshad to few verses of Holy Quran.
Thank you, sir. أعوذ بالله من الشيطان الرجيم بسم الله الرحمن الرحيم إنا أعطيناك الكوثر فصل لربك وانحر إن شانيك هو الأبتر صدق الله العظيم.
On behalf of Hyperuricemia Advisory Council and Farmevo, we formally welcome all the worthy guests, panelists, and our speakers for today's session. As you all know, Farmevo always remains at the forefront of academic activities, both in international and national arena, and as we go see in the Hyperuricemia, this is a fourth in line that this is 4th International Hyperuricemia Summit, which we are doing from today. Previously, all sessions are done on face-to-face session. We are very thankful for all our panelists and experts, all those things, but keeping the same legacy because of the COVID, it's not possible to do face-to-face, but we intend to do a smaller session in virtual online, and we are thankful to all of you for your active participation. Before we start, let me just briefly introduce our panel of experts and our speaker. As you all know, I'm Dr. Masood Javed. I am a medical director and at Farmevo Private Limited. And with us, the panel of experts included some of the leaders in this arena in Pakistan. Emeritus Professor Tasneem Ehsan. She is Dean at Medical Institute of Diabetes, Endocrinology and Metabolism in Karachi. We have with us Professor Dr. Yusuf Kamal. He is the first medical director and clinical dean at Aga Khan University Hospital. He remains as a chief operating officer, chief executive officer of Shaukat Khanum Cancer Hospital and project director and CEO Tabba Heart Hospital, Karachi. Thank you, sir, for joining in. We have Professor Dr. Khalid Mahmood Khan with us, who is professor of medicine and head of medicine department at Allama Iqbal Medical College, Lahore. Another worthy guest panelist is Professor Dr. Noman Tarif. He is the head of Department of Nephrology on Fatma Memorial Hospital, Lahore. We have with us Dr. Shahzadul Haq as well from Lahore. He is fellow of American College of Endocrinology and consultant endocrinologist, diabetes and metabolism. And the last panel of expert with us is Dr. Muhammad Tasadduq Khan from Karachi, my previous institute, Dow as well, which I belongs before joining Farmevo. He's assistant professor of nephrology and renal transplant physician of Dow International Hospital, attached with Dow University of Health Sciences. These are a panel of experts. We will share their comments in the end of presentation as well. Here, I'd like to introduce our worthy speaker, Professor Austin G. Strack. Thanks a lot for joining us in the 4th Hyperuricemia Summit as well. Dr. Austin is a professor and foundation chair of medicine at the School of Medicine, University of Limerick, and consultant nephrologist at University Hospital Limerick in Ireland. He received his fellowship from the University of Michigan, United States of America. He is trained in epidemiology and health outcome research at the Kidney Epidemiology and Cost Center and the United States Renal Data System Coordinating Center. Professor Strack's research focuses on chronic kidney diseases and acute kidney injury and the impact on clinical outcome. He has a particular interest in modifiable risk factor for disease, including anemia, iron deficiency, hyperuricemia, and their links with cardiovascular diseases. He is principal investigator of several large-scale studies that examines the burden, progression, and impact of CKD and AKI in health system. He is the co-investigator in international. He is co-investigator for the CKD surveillance program in the US and sits on several national and international steering committees and advisory groups. He was instrumental in establishing Ireland's first national renal information system, which we also look forward to establishing something in Pakistan as well. And now he's also leading the National Kidney Disease Surveillance Program. Recent efforts have additionally focused on addressing the impact of uric acid on kidney diseases outcome through different multiple large-scale trials. Professor Stack is the editorial board member of BMC Nephrology as well as Journal of Nephrology and is a reviewer for several major nephrology journals. His work has been funded by the American Heart Association, National Institute of Health, Irish Health Research Board, and Enterprise Ireland. He has also served as reviewer for the Wellcome Trust UK, Chief Scientist Officer for Research Scotland, and National Institute of Health. He is also the Patron-in-Chief of Hyperuricemia Advisory Council from Pakistan, and we warmly welcome Professor Austin for your talk today and looking forward for the another evidence-based studies and talk about the hyperuricemia and their role. Please, over to you, Professor Austin.
Masood, how are you? And thank you very much for the warm introduction. And thank you for inviting me to speak again at the 4th Hyperuricemia Summit in Pakistan, even though we're on the virtual mode. So let me just get my slide set organized, and I want to make sure I can see it and move it here just for 1 minute. I want you to give me the nod just to make sure you can see it.
Yes.
And I hope you can all see it at this point in time. Let me just do this.
You can see.
So thank you. Thanks for the introduction. And again, my big focus today is to, I suppose, give you an update on the landscape of hyperuricemia in 2020. A lot has happened since we spoke last and since we met. And I'd like to share some updates with you over the next 45 to 50 minutes. The title of the talk, I think it's important because it links elevations in uric acid to not just one single pathology, but a range of diseases. And that's why I've said hyperuricemia and its impact on cardio, renal, and metabolic disease. And I believe there's significant opportunities for the treatment of this in order to prevent some of these major diseases that can shorten an individual's lifespan and increase their morbidity in their life. And just to kind of start, I will share this first slide with you, just as to give you an idea of some of the challenges that you face in your clinics on a regular basis. So this is a patient of mine who I saw recently. He's an individual without gout, and this was his blood panel that we did as part of a routine review when he came back to clinic. And you will see, because it's highlighted, that the cholesterol is elevated, the total cholesterol, the LDL cholesterol is elevated, and the uric acid is considerably elevated as well. So from a risk reduction perspective, assuming that this individual had a pre-existing heart disease, one of the questions would be, well, do we treat the cholesterol? Do we have treatments to treat it? And you will say, yes, we do have effective treatments from clinical trials and good data to show that they're beneficial in improving outcomes. But what about the uric acid? It's considerably elevated. And assuming that that individual has followed, a diet, a low purine diet to reduce uric acid levels, and the levels are still elevated, what should we do with this? Should we treat it and hopefully reduce his risk of kidney disease or diabetes or high blood pressure or heart disease, or should we ignore it? And these are some of the fundamental questions that we see and we are challenged with, with our patients on a regular basis. From a kidney perspective, my big focus, of course, is in the prevention and treatment of kidney disease. And I want to share with you some data recently that in this world, there are over 850 million individuals with chronic kidney disease. So in any country, including Pakistan, the burden or the prevalence of CKD, chronic kidney disease, is between 10 to 15% of the population. That's a huge number. And it's an important number because it's extremely common. And there are two big consequences of this. And number one, patients are at risk of going into kidney failure. And secondly, they have a substantial risk of dying from heart disease. They're the two big risks of kidney disease. So we should do everything in our power to modify risk factors to try and prevent progression. And all of us know the standard traditional risk factors in terms of blood pressure, diabetes. So we need to control those and control them effectively. But there is a very strong body of evidence, an emerging body of evidence, that uric acid itself can increase the risk of kidney disease and also increase the risk of heart disease. And from a biological or a theoretical basis, there are a number of mechanisms by which this can happen. In the first, and this is something I shared with you previously, there is evidence from a biological perspective that hyperuricemia affects the lining of the blood vessels, the endothelial cells, and can cause or induce kidney disease and heart disease by a specific vascular injury. And that's been proven and shown biologically. But more recently, there's also a focus on the development of crystals, urate crystals, both in the kidney and both in the vessels of the heart, as another possibly independent mechanism through which hyperuricemia can cause kidney disease and heart disease. And that's just exploded in the last year or so. A second mechanism through which kidney disease and heart disease might occur is indirectly from high blood pressure, diabetes, and metabolic syndrome. And there is evidence that hyperuricemia can lead to the development of hypertension, diabetes, and these are known risk factors for both CKD and for cardiovascular events. From a kidney perspective, as I mentioned, there is good biological evidence from experiments that high levels of uric acid can directly damage the kidney. And it does it by a number of mechanisms. One, through elevation in blood pressure. Two, by narrowing the blood vessel that supplies the glomerulus. You remember that from medical school and from science, that the constriction of the afferent arteriole is one of the consequences, and that leads to ischemia of the kidney downstream, leading to what we call interstitial fibrosis. And this is a very nice model that was developed by Marilda Mazzali about 20 years ago. And there is good evidence that the hyperuricemia narrows the afferent arteriole, and you can see here on one of the slides, compared to control. So chronic persistent hyperuricemia causes progressive reduction in the lumen size. And there is evidence that the thickness of the arteriole, the afferent arteriole, correlates with the degree of blood pressure and the degree of hyperuricemia. Importantly, and which in my view helps the causality argument, if you pre-treat in animal models individuals with allopurinol, it lowers the uric acid and also lowers the blood pressure and reduces the degree of scarring in the kidney, the degree of interstitial fibrosis. And similarly with febuxostat, it has been shown, and again, it's nice to see experiments validated that in animal models, it lowers the uric acid and alleviates and prevents hypertension, and again, reduces the degree of scarring in the kidney. So these are important biologic arguments linking uric acid to chronic kidney disease, i.e. in the animal model. And so as a consequence of those studies, there is now an emerging construct that uric acid can cause this vasculopathy in the kidney and lead to hypertension in the longer term. And this is the model that Daniel Feig has proposed in the New England Journal some years ago. But as many of you know, in clinical populations, in the patients you and I treat on a regular basis, that there's a strong link between kidney disease and hyperuricemia. And you can see in this graph, the higher the levels of uric acid, the more likely patients have chronic kidney disease, hypertension, and obesity. So there's a very strong correlation between uric acid and these major chronic diseases or disorders. Importantly, I think there is nice evidence emerging that shows that uric acid, high levels of it, can predict the development of albuminuria. And as you know, the leaking of albumin through the kidney is one of the earliest detectable signs of kidney damage in clinical practice. And as you see in this study, patients who are in the highest tertiles of hyperuricemia had the greatest degree of albumin leak. You know, certainly individuals who had levels above 7 milligram per deciliter or 420 micromoles per liter. And if you put all the epidemiological studies together that have looked or assessed the association between uric acid and the likelihood of kidney disease, there is a fairly consistent, compelling picture that emerges. Whether these were investigators in Europe, in Asia, or in North America. And the compelling picture that emerges is that high levels of uric acid predict the development and progression of chronic kidney disease. Meta-analysis have confirmed that association, as this study by Sedeka has shown, that individuals who did not have kidney disease at baseline, but who were followed prospectively for the development of new-onset CKD, they showed that the risk of chronic kidney disease was increased for every 60 micromoles increase in uric acid, or for every 1 milligram per deciliter, the risk increased by about 18%. Similarly, and I think this is the big argument that I see, that uric acid is not just linked to kidney disease, it also predicts the development of hypertension, as shown by Grayson and colleagues. And equally compelling and important, it predicts the development of type 2 diabetes. And just to put things in perspective, this is a meta-analysis of prospective cohorts among individuals who did not have type 2 diabetes at baseline. And they were followed for the development of type 2 diabetes. And they compared the patients with the highest uric acid, a quartile, to the lowest, And again, they found a significant relationship in terms of risk of development of new-onset type 2 diabetes. So uric acid is linked in a longitudinal fashion to development of hypertension, diabetes, and chronic kidney disease. So almost certainly one would think it's linked to death and cardiovascular deaths, and that is quite true. And this is just one example of a study, a national study that confirms this. This is data from the US population from the NHANES. So when we looked at individuals from the US population and classified them by level of hyperuricemia, we found that the death rate increased with increasing level of uric acid. And it's particularly seems to jump up in uric acid levels between 300 or 370. That would be between 5 to 6 milligrams per deciliter in your units. And if you take into consideration other confounding factors like diabetes, high blood pressure, obesity, and gout, and adjust for those in multivariable models, you will still see that hyperuricemia independently predicts the development of cardiovascular death. This is really important. And you can see the risk increases with levels above 300 micromoles per liter. Again, we don't depend, evidence from one study doesn't change clinical practice. But if you consolidate all the observation studies together and look at mortality, you see a very similar picture. And in this meta-analysis by Kim, they found, and they showed quite nicely, that the risk of cardiovascular mortality was 16% higher amongst men and women with hyperuricemia versus those with a normal uric acid level. So coming along, there is the biological risk, there is the epidemiological evidence. What about treatment strategies? Is there evidence that lowering uric acid with a treatment like an xanthine oxidase inhibitor or a uric acid leads to better clinical outcomes? This is a very nice study by De Brule, who analyzed a pretty large database, population-based database in the UK. And they identified two groups of individuals. One, a cohort of patients with hyperuricemia, and secondly, a cohort of patients with gout. And to try and provide comparisons, they matched those individuals identically with those who they matched a group of those patients by the following. One, a group who had started allopurinol, and two, a group that did not. And what they found after follow-up for about 3 years, that individuals treated with allopurinol had a lower risk of death by about 11%. And in the gout cohort, their death risk was reduced by about 20%. So this is a suggestion that urate-lowering therapy has a beneficial effect on survival amongst patients with gout and also amongst patients with hyperuricemia without gout. So that's in terms of the initial signal that urate-lowering therapy may offer a clinical benefit in terms of a hard outcome. One of the questions we have been asking, and you've been asking, well, does lowering the uric acid protect kidney function? Does it prevent the progression of chronic kidney disease? And in one of the earlier small center-based clinical trials by Marin Gocochi in Spain, she found, and her research group, that individuals with CKD, stage 3, GFR 40 mils a minute, randomized to allopurinol versus placebo, and followed for up to 24 months, individuals who were randomized and who were treated with allopurinol had a lowering of their uric acid, as you might expect, but also their kidney function did not progress. In comparison, the placebo arm who did not get uric acid, their kidney function fell by about 3.3 mils a minute. In other words, there was a suggestion that allopurinol prevented the decline in kidney function in this small clinical trial by about 3 mils per minute in a calendar period. And similarly, another small clinical trial by Sisker evaluated the protective benefit of Febuxostat in protecting kidney function in a very short study. And again, similar to the Spanish study, individuals randomized to Febuxostat, their kidney function was protected at the end of the 6 months. So compared to the placebo arm, whose GFR dropped from 32 to 28 mils a minute, the kidney function in the Febuxostat arm did not fall, and surprisingly, it actually increased slightly. But the benefit or the difference was about 6.5 mils a minute, which is significant from a clinical perspective. So one of the challenges that all these have been smaller clinical studies, small clinical trials, and it can be hard to interpret those because they haven't looked at hard clinical outcomes. So what we do with small clinical trials to increase the sample size, we pool the results together in a meta-analysis and systematic review. And this was done about 3 years ago by Sue and colleagues, where they looked at that time at the existing 10 clinical trials that was published and reporting kidney events. And they found that in the pooled analysis, when they looked at major clinical events like kidney failure or a 50% decline in GFR or the need for dialysis, they found that uric-lowering therapy reduced that risk by 55%, suggesting, again, that lowering the uric acid has an important clinical effect. It's kidney protective in patients who are at risk of chronic kidney disease and kidney failure. One of the challenges, I suppose, from a physician and scientific perspective is, are all drugs the same? And clearly the best way to do that is a clinical trial, but observation studies can help us to kind of tease out the relative efficacy of one treatment versus another. And in this study that I'm going to show you, it's a large cohort study of over 3,000 individuals in Taiwan, followed for about 13 years, where they compared the relative efficacy of allopurinol, Febuxostat, and Benzbromarone, which we do not use in Europe, but they still use in some parts of Asia. And what they found when they looked at the progression of CKD, they found that only patients treated with Febuxostat and Benzbromarone had a benefit in terms of risk reduction, but the benefit was not seen with allopurinol. And the benefit was only seen if they achieved a uric acid less than 7 milligrams per deciliter. So suggesting that there might be one individual class effect or individual differences between different drugs, and at the same time that you need to get the uric acid down to a certain threshold before you get the ultimate benefit. So now I'd like to bring you up to the present and look at some recent clinical trials and try and make sense of those and how and whether or not they influence our clinical practice. So the first I'd like to present is the FEATHER trial, which, as many of you know, was conducted in Japan and reported by Kimura and colleagues in the American Journal of Kidney Disease in 2018. This was a modestly sized trial of 467 patients with CKD stage 3, mild to moderate CKD, and followed for up to 108 weeks. And they compared a low dose Febuxostat up to 40 milligrams daily versus placebo, no treatment, although some were on a low dose of allopurinol. And they looked in the change in GFR over time to see was there a benefit of Febuxostat in protecting kidney function. What they found is that there was no significant change in the GFR over time. There was minimal difference, no significant difference, except in patients who did not have proteinuria. And I don't know if you can see clearly the top right-hand graphic I have shown here because of our limited time. But what you will see is that the population they treated was a very low-risk population. In other words, they had a very low risk of progression, that their kidney function did not progress over time. So if you have a placebo arm that does not decline or that has no significant rate of progression, it'll be virtually impossible to detect any clinical benefit unless you've got a massive sample size. So this study was underpowered to detect that difference between the placebo and treatment. In fact, they said it was powered to detect a difference of 2.7 mils a minute. It certainly was not. And this is one of the challenges of conducting clinical trials and choosing the right sample size and a high-risk group for progression. The second clinical trial that I think deserves mention is the Freed study that was published in 2019 in the European Heart Journal. Again, this was a study conducted by Kojima and colleagues in Japan, and it assessed the efficacy of urate-lowering therapy with Febuxostat in elderly patients with high-risk cardiovascular disease and hyperuricemia. And they randomized over 1,000 individuals, followed them for up to 3 years, and they found the following. They found that individuals randomized to Febuxostat had a 25% reduction in a composite endpoint that included cardiovascular events and kidney disease progression. The overall hazard ratio was 0.75, indicating that there was a 25% reduction in that primary endpoint. And in fact, if you drill down to the data, much of that endpoint was driven by the kidney protective benefit, a lower risk in the progression of CKD. Now, more recently, we had 2 clinical trials published in the New England Journal. One by Dory and colleagues that evaluated the urate-lowering efficacy of allopurinol on kidney function in type 1 diabetes. And the second by Sunil Badwe that examined the efficacy of allopurinol in CKD progression, many of whom were not type 1 diabetic. I'm going to focus just in the essence of time on the second clinical trial. The second clinical trial was the CKD-FIX. And I believe it had some problems. So if you look at it, this was a randomized controlled clinical trial conducted in Australia that examined the efficacy of allopurinol, which was for many people a standard of care of the initial first-line therapy for urate-lowering treatment in patients with gout. But they examined allopurinol of doses up to 300 milligrams daily versus placebo in 369 patients, and they followed for 104 weeks. The inclusion criteria were individual with CKD stage 3, stage 4, and they included patients who either had albuminuria, which was quite significant, or were rapid progressors. In other words, their GFR decline was in excess of 3 mils per minute or more. And the outcome was a surrogate outcome, that is the change in GFR from baseline. And what they found is that there was no effect of allopurinol on the outcome of GFR. And this is here, as you can see from this slide. So the rate of progression in the allopurinol was -3 mL per minute per year. And in the placebo arm, the kidney function also dropped by about 3.3 mL per minute per year. Minimal difference and not significant. So the question is, does that mean that allopurinol or a uric lowering drug has no impact on kidney protection? Well, let's look at the CKD-FIX. First of all, the proposed sample size was 620 patients to give it a 90% power to detect a difference, a significant difference between the two treatment arms. Unfortunately, only 369 patients were included or recruited for the study. That's, in other words, the power of the study dropped to just 54%. Furthermore, there were significant drug discontinuation rates, 54 in the allopurinol group, 45 in placebo group. And we worked out that if you include those, that the effective power was dropped even further to 38%. And one of the other important things is that the inclusion criteria, they included patients, many of whom were normal uricemic. In other words, the threshold for inclusion in the study for uric acid was low. So I think when you include those issues into the trial, it does challenge the validity of the final conclusion. So that we have residual questions in terms of uric acid. And the primary one is it a true risk factor for CKD? And what can we learn from the recent clinical trials? So if it is a true risk factor, why are we getting different results from different clinical trials? Is it due to the sample size that, unfortunately, as you know, for clinical trials to detect a clinical effect, the trial has to be powered to detect a difference between the placebo arm and the treatment arm, depending on the event rate or the outcome in question. Did they include populations that had low risk of progression? And I think they did, certainly in the FEATHER trial. Were those patients included, were they really hyperuricemic? And this is an important question. If you don't include patients with an elevated serum uric acid, you may not detect anything. In other words, if you include patients who have normal blood pressure into your trial, do you think you're going to get a benefit from antihypertensive therapy? I would argue no. Another question is, are we using the right drug? Was allopurinol the appropriate uric lowering drug? Should Febuxostat have been the drug of choice, or a uricose uric? These are important questions that the academics and the clinicians have to debate. And the final thing I would say is, should gout patients be included in these studies? Because in many, many studies, gout patients, certainly in CKD, have been excluded from the clinical studies. One of the trials, and I think it's quite interesting, that I've been involved in recently, is the citrine study that has been just recently published this month or last month in the American Journal of Kidney Disease. And this is a very small pilot trial, just to let you know, where we examined the impact of Febuxostat and another drug, Virinurad, in protecting kidney function in patients with type 2 diabetes. And as you know, type 2 diabetes is the largest, population that are contributing to kidney disease globally as we speak. So we examined the efficacy of an intensive uric lowering strategy in type 2 diabetes, and patients were followed for up to 24 weeks. What we found is that if you really lower the uric acid with this combination, that you get a significant reduction in albuminuria, which was measured as the urine albumin to creatinine ratio. In fact, as early as week 1, we found almost a 39% reduction in albuminuria. At week 12, the primary endpoint, we got again about a 40% reduction, and the effect contributed right up to week 24. In other words, an intensive uric lowering strategy with febuxostat and verinurad led to a significant reduction in albuminuria. And as you know, that's the earliest detectable clinical sign of chronic kidney disease. And from that, a larger clinical trial is now underway called the Sapphire study as we speak, again, to look at the efficacy and confirm this benefit in over 700 individuals with CKD using a very intensive uric lowering strategy. In the last few slides, I would like to raise the issue of clinical trials and their outcomes and how we interpret them and how the results of these clinical trials get adopted and included into policy and into and recognized by boards like the Federal Drug Administration and the European Medicines Agency Board. The trials I'd like to review are the CARE clinical trial and the FAST clinical trial. And at the outset, let me say that the efficacy and safety of a drug can only be ascertained from well-designed, adequately powered, and well-executed clinical trials. That has to be the bar that we have to hold clinical trials, to account. They have to satisfy all those criteria to make sure they're valid. Now, as a preface, the CARE clinical trial was conducted as a post-licensing trial to examine the safety of febuxostat on cardiovascular events among patients with gout. And it came by because in previous studies of gout, there was a nominal or marginal increase in the number of cardiovascular events among febuxostat users than the placebo arm. So a marginal increase in cardiovascular events. And this was followed up by the confirmed study, a very short study, which found that there was no difference in cardiovascular events between allopurinol and febuxostat. But nevertheless, the licensing bodies, that's the FDA, and the European Medicines Agency mandated that a post-licensing clinical trial be conducted to assess the safety of febuxostat from a cardiovascular standpoint. And the first trial was the CARE trial. And the CARE trial was conducted in the US. It was mandated by the FDA and published in the New England Journal, the results of which in 2018. And this included, it was a large clinical trial of over 6,000 individuals with gout, all of whom had pre-existing cardiovascular disease. And these patients were followed for up to 3 years. And the primary outcome was a composite outcome of cardiovascular events, that is cardiovascular death, a non-fatal myocardial infarction, a non-fatal stroke, or angina with recurrent vascularization. And what they found, and you can see here, the primary outcome here shown in the cumulative hazard ratio, that there was no difference between febuxostat and allopurinol in terms of major adverse cardiovascular events. So no difference in their composite. However, when they examined both all-cause mortality and cardiovascular mortality, they found an adverse signal. They found that the number of deaths was higher in the Febuxostat group, and the number of cardiovascular events was higher in the Febuxostat arm versus the allopurinol arm, as you can see in these two graphics here, the Febuxostat in red and the allopurinol in blue. So a higher event rate. So the question was, well, what is going on here? Even though the primary outcome was negative, it was there was no difference, they found this higher signal in the Febuxostat arm. And following this, there was a debate, and eventually the FDA included a warning linking Febuxostat arm to cardiovascular events and death, and to be careful with regard to its clinical use in patients with gout. So we have to ask, when we look at these clinical trials, remember it was published in the New England Journal, and of course, that's a high impact journal, and that journal is read by everybody across the globe, and it carries significant weight. Was the CARE trial a well-designed clinical trial? Did it have any flaws? So my question is, was it flawed? And when we look at studies that are potentially flawed, we have to question the validity of those clinical studies. And in the first issue with the CARE trial was that over half the patients, 56.6% of patients, stopped the treatment prematurely. If you stop the treatment prematurely, we don't know what happened to those individuals in terms of potential benefit at risk thereafter. And certainly in the intention to treat analysis, it means that we don't understand, we don't have the information to say what happened to those individuals. And it's a significant amount of treatment discontinuation. The second issue was almost half, 45% of patients. Can you imagine? Almost half of the patients were lost. They lost them. They were lost to follow up. Where did they go? It means that they could not track their events after they were lost. Did they die? Did they survive? Did they leave the country? Did they go to Mexico? We don't know. They were lost to follow up. And the third issue was there was no biological plausibility as why, or no experimental evidence as why Febuxostat should have an adverse effect on the heart than allopurinol. Importantly, and this really didn't get out, when in this particular trial, when a post hoc, that's after the study was completed, investigators followed up, eventually tracked those individuals down who were lost to follow up. And when they did that, there was more deaths in the allopurinol group than in the Febuxostat group. And when they added those deaths to the original study, they found that there was actually no difference in mortality between both arms. But clearly, that does not get in to the frontline publication, and that did not get into the FDA. So these were some of the threats to validity with the CARE trial published in 2018. At the same time that the CARE clinical trial was published, the FAST clinical trial was already underway because the European Medicines Agency in Europe had mandated, like the US, a post-licensing clinical trial to assess the cardiovascular safety of Febuxostat versus a comparator, which was allopurinol. And this clinical trial was conducted by Thomas MacDonald and colleagues in the University of Dundee with an excellent group of investigators, including the Robertson Centre in Glasgow. And very similar to the CARE trial, this was a large clinical trial of over 6,000 individuals with gout who had at least one major cardiovascular risk factor. And these were randomized to Febuxostat versus allopurinol. Let me just say at the very outset, all these individuals had gout. All patients were on treatment prior to this with allopurinol. There was a screening period, and eventually they were randomized either to Febuxostat in a higher dose than in the US, that's 80 milligrams up to 120, versus allopurinol, in which the doses range between 100 and 900 milligrams. The primary outcome, that's the composite outcome, the primary was very similar to the CARE trial. That was major cardiovascular events, non-fatal MI, acute coronary syndrome, non-fatal stroke, and cardiovascular death. And this is the result here. You can see it here graphically, which I'll describe for you, but this is the hazard ratio. This looks at the rate of this composite outcome between the Febuxostat arm and the allopurinol arm. And as you can see, that the hazard ratio is 0.85, and the confidence interval just crosses 1. But in what it says here is that there is a lower risk of the composite outcome in the Febuxostat arm versus the allopurinol arm. But since it crosses 1, it means they're at least identical. And the p-value, because it was a non-inferiority trial, was highly significant and says there is no difference between Febuxostat or than allopurinol. Although, if you look at it, you can see that the event rate is actually higher in the allopurinol arm than in the Febuxostat arm. And you can see those both on the on-treatment analysis and in the intent to treat analysis. When they look at all-cause mortality, I think this is really important. When they looked at all-cause mortality, they found that the hazard ratio again was less than 1, favoring Febuxostat, but the confidence interval just crossed 1. Again, would indicate that there's absolutely no difference between both. But when they looked at superiority, they found there was a marginal effect. In other words, it was trending towards significance that Febuxostat was associated with a lower death rate, a lower event rate of mortality. And you can see this quite clearly in the cumulative hazard ratio. So there are more deaths occurring in the allopurinol arm than in the Febuxostat arm. So clearly, these results are completely in contrast to the CARE trial. And the question we have to ask, well, who do you believe? There are 2 clinical trials. So let's look at them head to head. Let's look at them head to head so we can see. So as you can see, large clinical trial, over 6,000 individuals in both. All patients with gout. Mean age, slightly older in the FAST trial than in the CARE trial. The CARE trial did have patients, they all had cardiovascular disease. The patient with gout had at least one major cardiovascular risk factor. The mean follow-up, somewhat longer in the FAST trial. But look at this again. In CARE trial, 56.6 stop treatment. In the FAST trial, it was certainly substantially lower, between 16 to 32%. Loss to follow-up, 45% in CARE, only 6%, 5.8% in the FAST trial. And again, if you look at the primary outcome, there was no difference in the CARE trial, and certainly no difference in the FAST trial. But again, the hazard ratio are lower in FAST than in CARE trial for Febuxostat. So this calls to question. So it looks at the very least from this large, well-conducted clinical trial that there was no difference in the primary composite endpoint and no hint of cardiovascular adverse outcomes with Febuxostat. There was no signal of an adverse cardiovascular events. In contrast, it looked like there was a beneficial effect with a lower rate of death for patients on Febuxostat. In the accompanying comment in the Lancet paper reviewed by Tom Barden and Pascal Richet from Paris, this is what they stated. The FAST results appear to be robust and reassuring with regard to cardiovascular tolerance to Febuxostat in the vast majority of white male patients with gout, although it does not allow firm conclusions to be drawn about patients with severe cardiovascular disease. These new data should prompt updates from the regulatory agencies on the cardiovascular risk of Febuxostat. And I do believe, as we go forward, that there will be debate, expert debate, and a review, and likely a change in the FDA warning that was attached to Febuxostat. So in the greater scheme of things, hyperuricemia is extremely common. The prevalence of hyperuricemia continues to grow over time globally, and certainly in the Western world. At the moment, hyperuricemia is mandated to be treated in patients with gout, although certain bodies, professional societies, have advanced guidelines to treat hyperuricemia in patients at high risk, patients with chronic kidney disease, patients with pre-existing cardiovascular conditions. And this is a guideline here from Japan, as you can see on your screen. To conclude, it is my view that uric acid is strongly linked to both kidney disease and heart disease. There are strong biological and epidemiological links, and there's emerging data from clinical trials to suggest clinical benefit. It does appear that lowering the levels appear to be protective against kidney disease progression, although not all clinical trials have shown this. And I would say some of those clinical trials, unfortunately, have had some inherent flaws. Febuxostat is more potent than allopurinol as a uric-lowering agent. And we know that from clinical evidence and clinical studies. And importantly, Febuxostat and allopurinol have equivalent effects on major cardiovascular outcomes. But it does appear from the FAST clinical trial that Febuxostat has a better effect on mortality. There was a lower rate of deaths with Febuxostat versus allopurinol. I do believe that the warning on Febuxostat by the FDA should be withdrawn. And I think we'll see more with this over the next number of months as the discussions happen amongst the regulatory bodies, certainly with the EMA and also the FDA. And I do believe that targeting hyperuricemia remains a key goal of intervention strategies. And that's why myself and colleagues across the globe continue to advance clinical studies and clinical trial, and more recently testing the efficacy of an intensive uric-lowering strategy on major kidney and cardiovascular outcomes. With that, I thank you for allowing me to talk with you today at the 4th Hyperuricemia Summit. I remember fondly my last visits to Pakistan over the last 3 to 4 years, and certainly this is a photograph from the 2nd Hyperuricemia Summit in Karachi. And as you can see, everybody in the photo is looking much younger there and looking so well. So thank you very much indeed from myself here at the University Hospital Limerick and University of Limerick and my collaborators. I'm delighted to present this talk and this information to you. Thank you very much indeed.
Thank you, Professor Austin Stark. Wonderful talk, and remembering the last picture. Yes, that was a picture from the 2nd, in which we have a poster competition as well. And 3 cities and the 1st, 2nd, 3rd are awarded as a gift as well. So now we have a small question answer session, as one of the panelists, Professor M. Shahzad, want to ask a question. So we'll start from there as well. Sir, can you ask your questions, and we go for the members' questions as well.
Well, appreciate it, Hamid. Thank you very much. And I must appreciate FARMIO for arranging and organizing this wonderful fourth Hyperuricemia Summit. And must compliment Professor Austin for such a wonderful review and a presentation. So we all know very well there is a strong correlation between hyperuricemia and metabolic syndrome. And briefly, the point which I would really be interested to ask is, at which point the pharmacological treatment should be initiated in hyperuricemia cases? Because quite a few federations, others suggest a cutoff of 9 milligram or above, or unless a patient has had a gouty arthritis case. So if a patient, even with a level of 6 or 5, had a gouty arthritis, we would treat a patient. Unless until no case with 9 plus, what's your take on that?
So that's an excellent question, and thank you for that. And so let me put things in perspective, as you rightly alluded. So for individuals with gout, the guidelines are quite clear that after the first episode of gout, every patient should ideally be initiated on urate-lowering therapy. And the target from many societies for individuals with gout should at least be 6 milligrams per deciliter. That should be the target. And for those with recurrent severe gout, it should be down to 5. So, and we know the lower the uric acid, the less likely individuals will get new gouty flares, and the more likely they'll have resolution of existing gouty tophi. So that is quite crystal clear. With regard to individuals who do not have gout, there is still debate on what first of all, the target should be, and what the level should be for initiation. However, I think there's compelling evidence from the epidemiological studies, and indeed from some of the interventional studies, that the lower the uric acid, the better. I would recommend that in individuals with hypertension, pre-existing cardiovascular disease like hypertension, and pre-existing cardiovascular risk factors, and levels of uric acid, certainly 9 or higher, should be targeted. So in my own clinical practice in patients with CKD, individuals with uric acid that are persistently in the 9 range, and certainly even in the 8 range, I initiate urate-lowering therapy. But I do that on the basis, number one, I have to inform patients about the benefits and what we're doing in terms of trying to protect kidney function, preventing progression to kidney failure, and also potential risks. We have to be open to patients in our discussions there. But like the Japanese guidelines, which I think they were first out of the blocks, the Japanese, in terms of that, and they have a high rates of hyperuricemia, and they're very fastidious in managing hyperuricemia in their population. And they have identified, so individuals who do not have gout, who have uric levels of about 8 to 9, they initiate therapy, and they aim for targets again down to the 6 range.
Appreciate it.
Okay, great. Thank you. One of the questions is the same, which is also already asked by Dr. Shehzad. Another question which we received from YouTube sharing is, what is the difference between hyperuricemia, gout, and pseudo-gout?
So gout, of course, is the condition that is due to the deposition of monosodium urate crystals in joints due to chronic and persistent elevation of hyperuricemia. So it means that you've had hyperuricemia for many, many years, and now, because of persistently elevated levels, crystals develop, get deposited in the joints, and not just the joints now, but what we now know, both the kidneys and the heart, leading to a chronic inflammatory arthritis that's painful, that leads to morbidity, and that destroys joints, and that can be treated with urate-lowering therapy. Asymptomatic hyperuricemia is the presence of hyperuricemia in individuals who do not have clinical gout. Now, let me just kind of expand this. I have to be honest, I am not a fan of the word asymptomatic hyperuricemia, because what it kind of translates and what people interpret it is that the uric acid levels are high, but it's not causing any badness, which is really not true. Because if you scan the joints of individuals with so-called asymptomatic hyperuricemia, you will find with DECT CT that they already have crystal deposition in the joints, in the tendons, and in other areas. So asymptomatic, of course, is individuals who do not have clinical gout, but that doesn't mean that they do not have uric deposition. They certainly do. And pseudo-gout is individuals that they don't have gout, they don't have monosodium crystals in their joint, they have another cause, but it does look like gout, but it's certainly not due to monosodium uric crystals. But I think it's important that when we think about asymptomatic hyperuricemia, that we don't ignore it as something innocent and benign. It is something that is causing badness to patients. It's affecting their vessels, it's affecting their heart, and it's affecting their kidneys.
Okay, wonderful. Thanks a lot. And the other questions which comes from the CARES trials and their things we already wonderfully covered in your session. They are already answered. Let me now go to our comments from the panel of experts. And first, I'd like to take the comments of Professor Tasneem Ahsan over the talk, and if they have any question.
Thank you, Dr. Masood Javed, and thank you, Professor Austin Stack, for that wonderful talk on hyperuricemia and the current status of where we stand with regards to research. It is interesting how we are perhaps progressing in the right direction now, because I remember from my training days and much later also, where you were told to institute uric acid lowering therapy after 3 attacks of gout in a year or something like that. And we've come a long way from there. So now we're saying 1 attack of gout, definitely, if somebody's had gout, go in with uric acid lowering therapy, and the more potent, the better. The problem with Febuxostat was the CARE trial and the warning that came with it for not using the potent drug Febuxostat that is available. So the publication that you just discussed, the FAST trial, clarifies some of the things, but we have to recognize that it is a slightly different study population. And I would suggest that it is perhaps better to be cautious with people with pre-existing cardiovascular disease, particularly heart failure and severe cardiovascular disease, before we have more data in that group of people. It absolutely makes sense. If this is if uric acid is something which is causing endothelial damage, it is bound to produce the damage to organs, particularly the cardiovascular system and the kidneys that you have talked about. And therefore, it makes sense for us to intervene early rather than late. So in the setting of CKD, for instance, it doesn't make sense for you to sit and wait that your uric acid is going to get to about 9 and then you're going to start treating it. So if you have stage 3 or 4 CKD, or perhaps even stage 2, it makes sense to bring that uric acid down to a level below 6. And similarly, multiple factors. And all of us clinicians, particularly in this country with the huge mounting load of metabolic diseases, type 2 diabetes and hypertension and ischemic heart disease, perhaps it is a drug, a uric acid lowering drug, is something that we should think about. But unfortunately, for the longest time, hyperuricemia has been a bit of an orphan, where it has stayed with the arthritis people for the longest time, and a bit with the kidney people, and nowhere else. So I think it's time that we kind of bring it into the realm of the general metabolic risk modification kind of platform, rather than just doing damage control at the end and treating gout.
Professor Tasneem, that's a fantastic comment. And I mean, what you said is so pragmatic and so sensible. I say well done on those comments. If I can get back to the first question, let me just respond to some of those. Excellently well said. The first, you're right. So, I mean, the FAST clinical trial and the CARE, you don't have exactly identical populations. And yes, in the CARE, they all had existing cardiovascular disease. But the FAST, about 30% of individuals had cardiovascular disease. Now, I haven't seen the fine print, but I think, and I know when they do the subgroup analysis, if there was a signal of adversity or worse in that subgroup, the 30%, I think we'd be hearing about it, and it wouldn't be coming out 10 months later or 2 years later. So yes, I think there might be a different population, and I think we need to be cautious because they weren't identical in terms of the spectrum of cardiovascular or the severity. But I think, in my view, individuals with gout, like 30% had cardiovascular disease. I bet you if you screen that remaining 70%, they'd have some evidence of cardiovascular disease as well, because gout and heart disease goes hand in hand. But I do take your comments and I appreciate them. The second thing, the second comment you made, I think is very well said. Historically, and even at the moment, sometimes we always intervene when the horse is bolted, when the damage is done, when they're on the verge of dialysis. And we have to get clever. And it's gratifying to see clinical trials being conducted across the globe looking at prevention at early stages. We've seen them with the SGLT2 inhibitors in the last couple of years, which has been very positive. And I do agree with you that I think uric acid, the initial focus was around the gout arena, rheumatology, but it is coming in towards the fold again. And you've got an emerging paradigm where cardiologists, endocrinologists, physicians with interest in metabolic disease, and nephrologists are coming together and focusing and trying to, I suppose, bring clarity on its importance and the importance of early treatment and early targeting of this to improve clinical outcomes. So I do agree with you that we need to intervene early, and oftentimes we have left it too late. So your comments are very well founded. So thank you for those.
Thank you.
Thank you. Thanks a lot, Professor Tasneem and Austin. Now we'd like to take comments from Dr. Yusuf Kamal. Sir, please.
Thank you.
Yes.
Thank you, Professor Stack. It was a wonderful presentation. It covered all the aspects, what we wanted to know about. It's a much broader area than what we thought, that it's a product of metabolism and the paradigm shift that is a marker of disease. I would very strongly endorse what my colleague, Dr. Tasneem said that last time when the ESC, there was a question of blood pressure and how do you treat it? And it was the paradigm that the lower the better, but it was changed to the earlier the better. And I think this is an issue we have to sort out, whether it is pre-diabetes, whether it's pre-hypertension, whether it's uric acid level of 7.5 in metabolic syndrome. I think we have to really treat this area, the earlier the better, rather than wait for things to develop and get out of hand. So, I mean, I would endorse the recommendation that somehow it should come into the guideline. It's always still coming in the guideline when you have one episode of gout or 2 episodes of gout to start this. So this is my comment, that we need to really enforce it and put it in the guideline. The other comment, and I want your opinion on it, that for a gout, is it better case where they had one episode of gout, to start with non-steroid anti-inflammatory agents and a low dose of colchicine first for the first few months before you add on the full dose of Febuxostat or Allopurinol?
Yeah. So great comments again, Dr. Kamal. Again, I suppose I'm saying I agree with you, but I think you've you've hit the nail on the head in a couple of issues. Certainly, just the guidelines you mentioned, and it does take time for things to get into guidelines. In the gout guidelines, certainly they have advanced with regard to one, the lower the better. Number two, early treatment. So they've actually followed what you just said, certainly in the realm of rheumatology. With regard to cardiology, they've been a bit slow off the mark, and I hope nobody's going to shoot me down for saying that. But it's only up to a year or two ago, even though gout patients have substantial cardiovascular risk, there wasn't a mention of gout in previous guidelines. But now it's in the ESC guidelines in terms of screening, evaluation, high risk. So it does take time. And I think we, clinicians, academicians, scientists, members of professional bodies, I think we do need to, we have a role to play in ensuring that, uric acid, gets a look in the clinical guidelines. And certainly, of course, it has to be, for the greatest extent, evidence-based, and where there's an absence, opinion or expert opinion, but ideally evidence-based. The final comment you had was, what was that final question again? Apologies. On my, oh yes, sorry, the treatment of gout. Apologies. So the treatment, yeah. So I'm a nephrologist, and I suppose as being a nephrologist, I'm not too enamored with the non-steroidals. That's my first comment. So I do agree a couple of things. Number one, that we need to treat the acute flare. And my typical choice is colchicine, unless it's polyarticular gout. So colchicine for acute flare, and then depending on the individual, low dose colchicine for up to a month or a couple of months. With regard to urate lowering therapy, in my own clinical practice, I started about 2 weeks later. I know the guidelines suggest you can start it there and then, but I kind of like to let things settle down, and I give about 2 weeks starting it. The thing about urate lowering therapy and treatment and management of hyperuricemia, it's a marathon, not a sprint. And I start low and go slow. So I typically start with low dose, but I titrate it up. And our nurse specialists that work with me, they're pretty fastidious, and they certainly do get the levels less than 6 and sometimes less than 5. And one of my colleagues who runs a big interest in gout and hyperuricemia, Fernando Perez Ruiz in Spain, has demonstrated the efficacy, a bit like heart failure therapy and heart failure nurse specialists. If you don't get the weight down, the volume control, you're not going to get good outcomes in the longer term. And it's the same with urate lowering therapy. So I start at a lower dose to try and, one, prevent acute gout flares, and two, to get a gradual decline in urate levels.
Thank you.
Thank you, Yusuf Kamal, Professor Yusuf Kamal. Now we're going to another panel of experts, professor who is very actively the whole time with the camera on as well. We'd like to share the Dr. Khalid Mahmood Khan Sahab to share their comments. Sir, please.
Assalamu alaikum, everyone. First of all, I'm really thankful, Dr. Austin, my dear friend from Limerick City, a beautiful city of Ireland. And once upon a time, I was there in 2002. You have given a wonderful talk and comparison of FAST and CARE trial. And you rightly said that Febuxostat, it reduce albuminuria, so it is helpful. In my opinion, this drug should be started earlier. So especially in our part of world, like in Pakistan, our cutoff value is 7 for male and 5.7 for female, because patient having that, like Professor Yusuf Kumar was rightly said, that our patient having diabetes or pre-diabetes, similarly pre-hypertension or hypertension, or any metabolic syndrome related with hyperuricemia. So these patients need these drugs much earlier. Though I know that those patients who are having gout, so I know that for gout to develop, levels are much more than this. But simple hyperuricemia that lead to vasculopathy, that lead to hypertension, that lead to diabetes, so we should treat at earlier level. And another thing, there was a question from audience that difference between gout and pseudo-gout. You have rightly said that gout related with uric acid crystal. But for pseudo-gout to develop, there are certain other parameters, like it is in patient with having hypercalcemia or high iron levels or low magnesium level, or sometimes it is linked with hypothyroidism. And moreover, pseudo-gout usually involve major joint like knee joint. On the other hand, gout usually involve big toe or things like that. So I think so. Thank you very much once again, Mr. Austin. Thank you.
Kelly, thank you very much, and thank you for. I hope you enjoyed your time in Limerick. You know, hopefully, maybe you might come back to Limerick in the near future, when in better times, when this pandemic has cooled down. I do agree with you in many of your comments, and like you said, there is, studies now linking albuminuria and the protective benefit of urate lowering therapy. So I agree, and I think many of us would agree. Like, clearly, I think we're preaching sometimes to the converted that earlier the better, at the first sign. So, like any risk factor, you want to treat the risk factor before the disease has happened. You want to get in there early, or at least at the earliest clinical sign. Now, at the moment, if you look at the recommendations from guidelines like the KDIGO or KDOQI or ASE, there's no recommendation to say, treat hyperuricemia if individuals have albuminuria. So that is why we are conducting this new larger clinical trial to look at the efficacy of this intensive urate lowering strategy in patients with albuminuria, to see will it reduce it in patients with early stage kidney disease. But I agree with you. I mean, I do think we need to start earlier. I think we need to be more proactive in our clinical strategy, and I think we certainly have to do this on a global basis. As I said, there's 850 million, almost 1 billion individuals with CKD. There's about 2.5 million patients on dialysis across the globe. If we don't get in early, those numbers are going to continue to rise. And some of them, as you know, may not get even treatment in their respective countries. So the onus is on us to kind of to lead the way in that regard. So I thank you again, Khalid, for your comments.
Thanks a lot, Professor Austin, and thanks a lot. It's a wonderful comments as we've given. So we are coming to the end of our session. It's a wonderful evidence-based scientific discussion and about the new studies, evidence which are coming up, and also some of the strengths and limitations for the evidence. Of course, the things have been changed, and we need to look forward in the evidence, in the clinical studies, what's going on, what is one guideline and what time may not be there after a few years of the clinical data and all other things. We try to work forward for the local data as well. From the day one of Hyperuricemia Advisory Council, we like to look forward for generating evidences in those things in the local scenario as well, instead of also with the international data. But our primary aim, one of the aim is to go for the studies, both controlled observationals and other studies in which we find out some differences and look forward for the national guidelines as well, and whether they are with the alignment with others as well. Now, I'd like to thanks a lot, Austin, for the wonderful talk and your for time, as well as our panel of experts, Professor Tasneem Ahsan, Dr. Yusuf Kamal, Dr. Khalid Mahmood Khan, Dr. Nauman Tarif, Dr. Shahzadullah, and Mohammad Tasadduq Khan, with also the wonderful participants. Have an interactive session. And hopefully in next year, we like to see you in person, in face-to-face, in the hopefully in the post-COVID era. And we're going to do that 5th Hyperuricemia Advisory Conference in face-to-face in all the wonderful cities of Karachi. And we like to host you, looking forward to as well. So wonderful, thanks a lot. And the recording will be available on the YouTube channel. So any person who want to revisit the things as well, want to comment on anything, like to share with other people, we are most happy to do so. Thanks a lot, and thanks a lot from the FARMEO as well. Thank you.
Thank you very much indeed. Thank you. And thank you for giving me the opportunity. And I look forward to returning to Pakistan and meeting with many of you, and hopefully all of you face to face in better times. So take care, and bye-bye now from Limerick.
Thank you, Professor Stack, and thank you, FARMEO and everyone. Thank you.
Bye-bye now. Bye-bye now.